I am Dr. Selvaraj, your surgical educator from Malaysia. Welcome back to my series of surgical teaching videocasts. These are meant mainly for undergraduate medical students doing the surgical clerkship rotation. I promise you will become competent in clinical problem solving and surgical decision making if you are going to watch these videos over and over again. Today, in this episode, I am going to discuss one more set of 10 MCQs on carcinoma of head of the pancreas, one of the important cause for obstructive jaundice. So, I need not emphasize the importance of MCQs because you are appearing for this type of exam or the assessment in your qualifying exams like MBBS, MS, MRCS and all. Apart from that, exclusively in your medical competitive medical entrance exams, you are having exclusively only MCQ. Okay, so that is why you must know how to tackle these MCQs, and this series of MCQ videos will give you a systematic way of revising the whole spectrum of general surgery topic by topic. So here in this episode, you see, I am not discussing all other MCQs. So all MCQs in this video is going to be connected with carcinoma of head of the pancreas. So, but before going to discuss those 10 MCQs in this episode, I want all of you to go and watch my original video in my YouTube channel regarding the CA head of the pancreas. Go and watch that video first, and then you come back to this video and let us discuss the 10 MCQs. So coming to the MCQ number 1, a 65-year-old man present with painless jaundice, dark urine, weight loss and pruritus. On examination, he has a palpable gallbladder. What is the most likely diagnosis? A. Chronic pancreatitis. B. Gallstone in the common bile duct, that is cholelithiasis. C. Carcinoma head of pancreas. D. Primary sclerosing cholangitis. Of course, the correct answer is C. Carcinoma head of the pancreas. Why it is correct? Courvoisier's law that states painless jaundice plus palpable gallbladder is classic for malignant CBD obstruction, most often from pancreatic head carcinoma. Okay, chronic pancreatitis present with severe pain and calcification. Okay, here there is no pain because the obstructive jaundice because of carcinoma head of the pancreas is painless and progressive jaundice. And then gallstone in the common bile duct, cholelithiasis, usually painful and intermittent jaundice. And C is the correct answer. Primary sclerosing cholangitis seen in younger patients, those who are having inflammatory bowel disease like ulcerative colitis, and rarely with gallbladder enlargement. Gallbladder enlargement won't be there. Reference is the 28th edition of Bailey and Love, chapter 67. Coming to MCQ number 2, a 60-year-old male with jaundice undergoes abdominal ultrasound which shows a dilated common bile duct and a hypoechoic lesion in the head of the pancreas. What is the next best investigation? A. Liver biopsy. B. CT scan of the abdomen. C. ERCP. And D. MRCP. Of course, the correct answer is B. CT scan of the abdomen, CECT. The triphasic contrast enhancement CT is essential for staging and the resectability assessment of the tumor in the head of the pancreas. So this is the investigation of choice. Liver biopsy not required unless metastasis is suspected. ERCP is therapeutic but not the first line for staging. D. MRCP provides biliary detail but lacks staging information. So for staging purpose, you must do CECT of the abdomen. Reference Sebastian's textbook of surgery, 21st edition, chapter 51. Coming to MCQ number 3, a patient with carcinoma of pancreatic head is found to have portal vein involvement on imaging. What does this indicate? A. Early stage with resectable disease. B. Locally advanced unresectable disease. C. Metastatic disease. D. Benign structure. Of course, the correct answer is B. Locally advanced and unresectable. Explanation: because of vascular invasion, that is the portal vein involvement, is a common criteria for unresectability. Early stage resectable disease, no. Vascular invasion excludes resectability. It is unresectable tumor. And then B is the correct answer. C is metastasis. It is not metastasis. Refers to distant spread, not local invasion. Here it is only local invasion of the portal vein. And D is benign stricture. Strictures do not involve vascular encashment. So here it is vascular involvement is there. So it is unresectable tumor. Reference Squad Surgery 11th edition, Pancreas chapter. MCQ number 4. A 58-year-old man presents with new onset diabetes, weight loss, and vague abdominal pain. Labs show elevated bilirubin. What is the most likely cause? A. Type 2 diabetes mellitus. B. Carcinoma head of the pancreas. C. Autoimmune pancreatitis. And D. Duodenal ulcer. The correct answer is, of course, B. Carcinoma head of the pancreas. Because of new onset diabetes after age 50 with weight loss and jaundice should prompt suspicion of pancreatic cancer. Okay, A is type 2 diabetes. It doesn't explain jaundice. So type 2 diabetes, why they should have jaundice? So it is not correct. B is the correct answer. Autoimmune pancreatitis C is very rare and it responds to steroids. D, duodenal ulcer, it does not cause jaundice. In duodenal ulcer, there is no association with jaundice or diabetes. Reference is Davidson Medicine, 24th edition. MCQ number 5. A patient with obstructive jaundice is diagnosed with unresectable pancreatic head carcinoma. He has severe pruritus and hyperbilirubinemia. What is the most appropriate next step? A. Immediate chemotherapy. B. Palliative biliary stenting. C. Surgical bypass. D. Percutaneous liver biopsy. Of course, the correct answer is B. Palliative biliary stenting. Endoscopic biliary stenting via ERCP relieves cholestasis and pruritus. A. Chemotherapy is delayed until biliary drainage. Yeah, after that only you have to give chemotherapy. B is the correct answer. C. Surgical bypass. It is more invasive than necessary. So biliary stenting alone is more than enough. We need not do surgical bypass at this stage. D. Percutaneous liver biopsy not indicated in obvious obstructive jaundice. Reference again Sebastian's surgery, 21st edition. MCQ number 6. During staging of pancreatic cancer, Ca 99 is found to be 900 units per ml. Normal is less than 37. What is the implication? A. It confirms diagnosis of pancreatic cancer. B. Suggests complete resectability. C. Supports diagnosis but is not specific. D. Indicates benign disease. Of course, the correct answer is C. Supports diagnosis but it is not specific. Explanation: CA99 is a tumor marker used for monitoring. It can be elevated in benign obstruction also. So it is not diagnostic. It is supporting the diagnosis but is not specific. Confirms diagnosis of pancreatic cancer. It is not, confirmatory. And B is suggests complete resectability. No. Level does not predict resectability. C is the correct answer. Okay. D indicates benign disease. High level suggests malignancy, not benign process. So reference is 28th edition of Bayesian law. MCQ 7, a 68-year-old patient undergoes Whipple's procedure for carcinoma head of the pancreas. On pathology, the tumor is T2, N1 and M0. What is the next best step? A. Radiotherapy alone. B. Observation. C. Adjuvant chemotherapy. D. Total pancreatectomy. Of course, the correct answer is C. Adjuvant chemotherapy. Because post-resection adjuvant chemotherapy with gemcitabine improves survival in non-node positive disease. Radiotherapy alone, not a standard treatment. Observation, inadequate for stage 2. Adjuvant chemotherapy is the correct answer. Total pancreatectomy, already patient has Whipple's. Total resection is unnecessary. You have to remove only the head of the pancreas or pancreatoduodenectomy. Reference is SWOT surgery, 11th edition. Coming to MCQ 8. Which of the following is the most common histological type of pancreatic, head of the pancreas cancer? A. Neuroendocrine tumor. B. Adenosquamous carcinoma. C. Ductal adenocarcinoma. And D. Mucinous cystadenoma. The correct answer is C. The ductal adenocarcinoma. More than 80% of the pancreatic head cancers are ductal adenocarcinoma. The neuroendocrine tumor, the incidence is only less than 5%. Adenosquamous carcinoma is very rare, aggressive variant. D. Ductal adenocarcinoma is the most, C is the ductal adenocarcinoma is the more common type, and D is the mucinous carcinoma, cystadenoma, that is benign or borderline cystic lesion. Robbins, reference is Robbins pathological basis of disease, 10th edition. Coming to MCQ number 9, what is the classic triad of symptoms in pancreatic head cancer? A. Hematemesis, pain and vomiting. Jaundice, weight loss and palpable gallbladder. Ascites, fever, diarrhea. Palpable mass, hypotension and confusion. The correct answer is of course B. Jaundice, weight loss and palpable gallbladder. Explanation: this triad is common in head of the pancreas tumor. All other choices A, C and D are non-specific or unrelated to CA head of the pancreas. Reference is Davidson's 24th edition. Coming to MCQ number 10, which surgical procedure is the standard curative option for resectable carcinoma of the head of the pancreas? A. Distal pancreatectomy. B. Total pancreatectomy. C. Whipple's procedure. D. Enucleation. Of course, the correct answer is C. Whipple's procedure. Pancreatoduodenectomy, Whipple's, is the gold standard for resectable pancreatic head of the tumor cancer. Distal pancreatomy is only for body and tail lesion. Total pancreatectomy rarely indicated due to high morbidity. And enucleation is used in benign tumors. Reference is the 28th edition of Bailey and Love, chapter 67. So, these are the reference books. The first two books are problem-oriented, problem-based books, these two books. In the whole literature, there are only 5 books are there. Apart from these 2 books, one more is learning surgery. So this is Hunt and Marshall's 3rd edition of clinical problems in surgery, and the clinical surgery made easy by Mohan D. Silva, 3rd edition. So these 2 are the problem-based books. The all other books which I have mentioned here are having case scenario-based books. So better you solve all the problems, the case scenarios in these books. Maybe you can get all of them from your library. So you try to solve all these things, because nowadays they are going to ask you in all the entrance exam, like those who are appearing for NEET PG and NEET SS or FMGE, all these exams, they are going to ask only case-based or scenario-based questions like USMLE. So you have to work all these books also. Just reading Bailey and Love and Sebastian alone is definitely not enough. You go and click this link. So you will see what are the different books are available, the latest books available for you to become a competent or expert surgeon. So this is my own book I have created for my students in my institution. This contains more than 120 case scenarios. You can go click this link and download this book, or here if you click, you can see a series of videos. There are 9 modules in this book. So each module I have created a video. So I will be discussing the same case scenario in these books, and I will be discussing the answers also. So either you can download the book and you can read on yourself, or you can go there and watch my teaching also. So thank you very much for watching this video. If you think that all these videos are very helpful to you, kindly share these videos in your social media. Kindly click the bell button also to get notified regarding my latest uploads. Thank you once again for watching this video. Let us meet in yet another episode. Until then, bye-bye.